Yeah, it just always amazes me when you think about 1 minute you go from kickback in the recliner, letting your dinner settle, watching a movie, to you're treating 100 gunshot victims at a mass shooting.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
Happy New Year.
Happy New Year, Matt. It's been a while since we took a break.
Yeah, took a nice holiday break. Did you have a good Christmas and all that stuff?
I did. What did Santa bring you?
What did I get? Some clothes.
Clothes? Yeah, me too. Clothes. I need clothes.
Yeah. Clothes, that's about it.
Yeah.
Nothing exciting.
Yeah.
Nothing. I mean, when you get to be our age, just making it to the next Christmas is exciting.
Well, you speak for yourself.
Yeah. Well, but over New Year's, had some exciting events. We're about to do a hemorrhage lecture. We've been working on a hemorrhage lecture that we're excited about. But there was they're now calling it a terrorist attack that happened in New Orleans.
Terrible. It really is terrible.
Absolutely terrible. Tragic, super tragic. Mm-hmm. And it just kind of brings to mind, trauma, mass casualty incidents. Yeah. Unfortunately, these are becoming more and more commonplace in our nation.
Whether it's a shooting or a truck into a crowd.
Yeah.
Natural disasters.
Yeah. Yeah, these mass casualty incidents where you have lots of victims. I think, what was the last time we looked? There was 15 dead
and 35 injured, I think.
Yeah, in New Orleans. So it's, these are incidents that, it always amazes me how you're sitting around the firehouse or wherever, and you just never know what the next call is going to be. No. It might be a poo-poo pain at the nursing home. It might be grandma fell out of bed, or it might be a truck just, drove through a crowd of thousands of people. And it's, now it's the call, And
it's the same way in the ER. I never know what ambulance call I'm going to get. I don't know what trauma's going to come in or who's going to bang on the ambulance doors. Those are always some of the sickest patients that you see. Yeah. And they're amazing. It's amazing how sick somebody could be walking in, too.
Yeah.
Yeah.
Yeah, it just always amazes me when you think about 1 minute you go from kickback in the recliner, letting your dinner settle, watching a movie, to you're treating 100 gunshot victims at a mass shooting. I mean, God forbid that happens, but it does happen. And we have to be prepared for it to happen. And again, that's why we always talk about education is so important, because these are once in a career calls. I mean, I've been in the fire service 20 years. Yeah, I've had my fair share of gunshot victims. Most of those have been, unfortunately, self-inflicted. I've had some gunshot victims that weren't self-inflicted wounds. But it's rare, unless you work in a major urban area, going on a lot of trauma, gunshot victims, stabbings, things like that, it's not very common.
Yeah, that's right. I used to work at a level 1 trauma center in a state not too far from here. Yeah. And we were a catchment area for the whole state. And it was, we saw a lot of trauma. Some of the institutions I've trained at, too, just a lot of trauma. It can be so much different in the rural setting versus the urban.
Yeah.
But the pathophysiology is all the same.
Exactly.
With a truck hitting a group of people, it's not uncommon in our ER to see somebody who was hit by a car.
Yeah.
Not common to have 35 people hit by a car.
Yes,
right?
all coming in within an hour.
Yes.
Yeah.
And so it really can overrun, which is the definition of an MCI, but it will overrun your EMS system.
And I think that's important to talk about if you're a one ambulance department, you could have a bad wreck on a county road and have 3 critical patients. That's an MCI to your agency, because it is overloading what you have available to you. Yeah. So, obviously New Orleans, we met the folks from New Orleans EMS, great folks. They've got a good system down there, their fire department, New Orleans EMS. Sure that they were well prepared for an event like this.
Yeah, being prepared, that's a key, right? I mean, exactly. What types of injuries would you see with, I don't know specifically what they saw there on Bourbon Street, or I think it was on Bourbon.
Yeah.
But, it could have been, a blunt trauma.
For sure, blunt traumas.
Right?
Yep.
You could have had massive internal bleeding.
Head injuries, extremity fractures.
Crush injuries, driven over potentially.
Yep.
Of the 15 people that died, being very comfortable with the triage system too is important.
That's right. Yeah, whatever, everybody uses a little bit different system. But the point is that if you are the first folks on that scene, your job is not to treat. Your job is to identify who are the blacks, who are the patients that are not going to survive this. Because what is our end goal on these MCIs? Our end goal is to save the most amount of people possible, right? And to do that, we have to be really good at triage. So that we know the ones that aren't savable, which on a regular call, we would work those patients. In these situations, we don't have the resources to work every one of these patients.
Because you'll lose other people that are salvaged.
Exactly. You're going to spend all these resources on somebody that's probably not going to live, and 10 other people die because of it. That's why we have to do this. And I've never worked a real MCI like this. I can only imagine that's a really difficult thing to do, to walk past somebody who typically you would stay and work on, to go and help other people, But yeah, your initial goal is to triage and identify who are my blacks, who are my greens, who are my yellows, who are my reds. The greens, everybody learns that in classes. Hey, if you can hear my voice, come follow me. And you get those people, if they can walk and they're ambulatory, they're probably not going to die within the next hour. Move them. Now, one thing to remember about MCIs is their colors can change. They might be a green initially, and they might progress to a yellow or a red. Right. So we're constantly reassessing. But
reassessment. Yeah.
Difficult situations for sure.
It's a paradigm shift too. I know when the Spanish flu hit more than 100 years ago.
Were you there?
Yeah, I was. I'm not that old. But there's a reverse triage. Even back then, it's like you don't have the resources to treat like you do. Typically, in the ER, the sickest patient in the hospital, the sickest patient in the ER is going to utilize most of the resources at that moment, right?
That's right.
They got that cardiac arrest, the guy that coded in room 2, and we'll all come in and work our hardest on the sickest. In a triage MCI situation, the sickest, or maybe the ones that are already dead or whatever, you don't work
waste
them.
Your time with
you can't, and and that's again, when you have other bystanders there, that they're not going to understand that. Why aren't they taking care of this? Or even checking this guy. What if he's not dead? There's a reverse triage mentality that we have to be really good at, and it's difficult.
The other thing I think we have to be really good at in these situations is doing those skills that we don't often do, right? I mean, tourniquet placement, we should be practicing with those a lot. But when somebody's bleeding out of their femoral artery, you better be pretty proficient at putting on a tourniquet or two. You're not going to have time to be like, oh, what's this? You have to practice with those things. Where is the bleed? Go high and tight.
Where's the tourniquet?
Yes, exactly. Knowing where your equipment is. It's funny, but it's not funny because it's super important. You got to know your bags. You got to know where your equipment is. Throwing a chest seal on, throwing in an NPA, an OPA, doing needle decompression, where to do it, how to identify those landmarks. If you're critical care and you're doing finger thoracostomies, because we're talking about blunt trauma, you're probably not going to be doing a pericardial centesis in a mass casualty situation. But these skills are skills that you have to be able to quickly identify. Number one, this is what the patient needs, knowing where that equipment is, and knowing how to do it. Super, super important.
Yeah, part of I think the underappreciated part of it is the assessment. Is like identifying the pathophysiology, identifying the disease, and then knowing how to treat it.
Do they need a needle decompression? Are they showing signs of attention pneumo? Do they really need me to do this right now? Do they need a tourniquet? I mean, I've seen a lot of times these videos that you see online, people just throwing tourniquets on. And is it probably going to have a bad outcome? No, it's probably not if there's a gunshot wound or something. But, if you watch our hemorrhage lecture that we're going to talk about, we go into much more detail about when to put on tourniquets, what to look for, things like that.
Some of the signs of hemorrhagic shock.
But head injuries. I'm sure that there was probably multiple head injuries with this guy blasting through in a truck. The videos are pretty hard to watch. It's scary thinking, that's a 6,000-7,000 pound missile coming at you however fast he was going.
Some of the video footage I saw, really, really fast.
Oh, yeah, he's moving.
Moving fast.
Yeah.
Yeah, for sure. Head injuries, blunt trauma, chest, abdominal trauma,
bleeding, internal bleeding. Yep.
Potential vascular injuries in an extremity, needing a tourniquet potentially. Crush injuries, which cause a whole other group of problems down the line.
That's right.
And then there's also airway emergencies too, right?
Yeah.
That's always a concern.
Absolutely.
Anytime you have massive injuries, you've got to think about the airway support.
I think it's important to talk really quick about, and again, we talk way more about this in our lecture, but what's the trauma triangle, right, that we always talk about?
The danger triad
yeah.
or whatever.
Yeah, exactly.
Hypothermia.
That's one that when I'm teaching, especially here in Texas, we don't think about it.
Yeah.
Because it might be a summer day here in Texas and it's 100 degrees outside. Yeah. And what do we have going in the back of the ambulance? We got that AC cranking, right? You're a big guy. Yeah. You're hot-natured. We get in back. We're stressed. We're working. We're dumping sweat. And we forget, but your patient is losing volume, which means their temperature is dropping.
Yeah.
And we don't think about, they get a little bit cold, they'll be fine. No. That is a huge factor. We've got to keep these trauma patients
which is related to hypercoagulability.
Exactly.
That's another part of the triad. And then, of course, acidosis.
Acidosis, that's right. Yeah, and they're losing blood. And I think it's crucial because I still see people doing this. Yeah. When I went through paramedic school, it was 2 large bore IVs and give them a bunch of fluids. Yeah. That's not helping these patients. As a matter of fact, it's killing these patients. Mm-hmm. You're pouring this fluid that does not have hemoglobin, does not carry oxygen, which is... Go ahead.
Oh, yeah. You're making the bleeding problem worse.
Yes.
You're adding water to a liquid that can coagulate and stop bleeding.
You're blowing the clots.
Making it more dilute.
That's right.
You're also, based on literature we've learned, and we've talked about in our lectures, is you're making the blood vessels more permeable, too.
That's right.
They leak more.
That's right.
So
you're making leaky vessels leaky.
And they leak more.
Yes.
So you got to be really careful with fluids. That's not the answer. We want to replace what we lost.
That's right. And define that, because there could be some confusion when you make that statement.
So when you bleed out 40% of your blood onto the asphalt.
Yes, I was bleeding out my own blood.
5 minutes before this all happened, everything was fine and dandy.
Yeah.
Your heart, your pump's fine, your blood vessels are fine, everything's fine, blood pressure, vitals are fine. And then you have some sort of an insult and you lose a bunch of blood onto the pavement. Mm-hmm. So the problem was the blood on the pavement.
That's right.
So we want to solve that problem, get the blood back in.
The blood back in, yes. Right. Yeah.
So you can again, we talk about this in the lecture, but this is important to understand, is that you could bleed every bit of blood out of your body except for one drop. Your hemoglobin never changed. That's a concentration. I know it's a blood value that we don't check in the ambulance.
Yeah.
The key is
but the critical care folks can.
The critical care, Yes. So the average hemoglobin of a man, mine might be 14 or 15.
I just go with 15 across the board.
15 across the board.
15 for male and female.
If you're on testosterone, you might be at 22.
Right, but that's, right.
Or COPD, right?
Yeah.
Polycythemia.
Yeah.
But my hemoglobin is probably around 14 or 15,
right.
I'm guessing. I think for women, it's typically a little bit lower. For men, it's typically a little bit higher. But that's a concentration. So if I were to measure my hemoglobin right now, couldn't measure my hemoglobin, all right, it's about 15, right? Now I'm going to take a bucket, I'm going to bleed everything out of my body except for one drop.
Your hemoglobin.
A lot of times people will think, well, your hemoglobin's really, really low now.
Yeah.
No.
Still 15.
Still 15.
Yeah.
It's a concentration. I just don't have much of it. It's a volume problem. I need to get that blood back in.
That's right.
Acutely. Now, chronically, my hemoglobin can fall. Mm-hmm. Because I'm bleeding slowly, and my kidneys will respond by reabsorbing more fluid to maintain volume. Mm-hmm. But what happens, though, is my blood becomes more dilute.
That's right.
And as my blood becomes more dilute, my hemoglobin concentration goes down and down and down.
Yeah.
If I slam a bunch of blood on somebody that's chronically lost blood over time, I could kill my patient.
That's right.
By giving them too much blood and volume overloading their pumps, especially if they have heart disease.
Yep.
It's a really interesting difference between chronic blood loss and acute blood loss.
That's right.
When you're hit by a truck and you're losing blood onto the pavement in a matter of seconds, you go into hemorrhagic shock quickly because of blood loss.
That's right.
The way to fix it is to give them the blood back.
That's right.
Fluids can make it worse.
That's right. Too much fluids. Yeah, I mean, a little bit. You got to have a little bit of volume, and if that's all you carry, so I think looking at this from a provider level,
Yeah.
But EMTs, obviously, most EMTs don't start IVs.
Yeah.
So the crucial thing is to stop the bleeding.
Right.
And in all of these cases, whether you're an EMT, a paramedic, or a critical care paramedic, the point is we can't fix this in the field.
Right.
We have got to get these patients to a trauma facility.
Correct.
We've got to get them to a doctor. We've got to get them to a trauma surgeon quickly. So EMTs, stop that bleeding however you can. Pressure, tourniquets, whatever you can do, get them in the back and go. Paramedics, you can do some more things, but don't waste a ton of time on scene doing these things. You can be doing those things en route. Even the critical care folks,
Don't stay and play. This is the time to load and go.
That's right. That's right. You can do a lot of these things en route. Sorry, I interrupted you. What were you going to say?
No, this is actually pretty controversial because there are a lot of departments across the country who presented with a case, person hit by a truck, required 2 tourniquets to stop a massive bleed, blood all over the asphalt. Blood pressure is 80 over 40. This guy needs fluids.
No.
Slam a leader. No, we don't do that. That is not
hypotension.
Good. That's exactly right. Permissive hypotension. In fact, I talked to a trauma surgeon that I worked with. We were treating a very sick patient. In fact, one of the sickest patients I've ever treated involved a car fire and massive deceleration into a bridge pillar and
I remember you.
ED thoracotomy, 4 chest. This guy was sick, right?
Yeah.
I was talking to my trauma surgeon a little bit as this patient was getting shipped off to the OR. And he's saying, I would be so happy if a trauma patient comes in with a blood pressure of 70 over 40.
Absolutely.
Right?
Yeah.
I think one of the important things, and don't just focus on the numbers.
No.
You see a low blood pressure, but you've stopped all bleeding, or well, from what you can tell, you've stopped bleeding maybe in an extremity or whatever it was. And you're talking to the patient, constant reassessment. The sicker your patient is, the more often you should be reassessing. Wow, the mental status is declining. There must be something else going on.
What else is bleeding?
And if all you have is fluids, and you may have to give some fluids.
Right. Or pressors might be helpful, depending on what kind of pressors you have.
Follow your protocol, right?
Yep.
I think the pathophysiology though of a young person who was hit hard by a car, or maybe there was some sort of an injury of some kind, a car accident. Let's just use that as an example. Maybe a shark bite, right?
Yeah.
The injury of these shark bites that we studied in our lecture that we just filmed is really about hose damage.
Yeah.
The pump's fine.
That's right.
The pump is fine.
Yes.
It's the hoses that got torn up, and we're losing fluid out of these hoses. We can understand that.
An easy way to remember it, we've said it before. Is it a pump problem? Is it a hose problem? Or is it a fluid problem? Right? If you're losing blood, that's a fluid problem. You're pumping your hoses. One of your hoses got busted, which is why you lost the fluid, right? But you got to clamp off that hose, and then replace what you lost, right? If it's a pump problem, that's probably not going to be a trauma-related thing. That's going to be a medical-related thing. So when you're thinking about it as a paramedic, like, okay, the heart's probably fine, especially if you're dealing with a 25-year-old trauma patient.
Right.
The pump is fine.
Most of the people hit by that truck were probably youngish.
I'm sure. Yeah, there's probably not a lot of 80-year-olds that were partying on Bourbon Street.
I'm
sure there was one or two. Go have fun.
Right.
You do you. But you're right. You have to look at that, and we can't look at things the same. It's like working a trauma arrest. I remember teaching when we started to make a shift of, and we've talked about this before, beating into people's head, chest compressions, chest compressions, chest compressions. And then we go into trauma arrest, it's like, hold on the chest compressions. Let's address what the trauma was first. Let's do skills first, whether that's needle decompression, finger thoracostomies, pericardial centesis, whatever the case may be, let's address that first and not do chest compressions. And I was teaching that at departments, and guys were losing their minds, like, are you telling me I'm not supposed to do chest compressions in a patient in cardiac arrest? And I'm saying,
maybe.
I'm not telling you not to. I'm telling you that's not your number one priority, because we have to think about the pathophysiology of what's going on. If your pump on your fire truck, if you have not hooked up to a hydrant yet and you have run out of tank water, is it a smart idea to crank up your pump? No, you're going to cavitate your pump. You got to fill that tank back up before you can turn your pump back on. Well, if you go jumping on the chest of a trauma patient, you're just pumping out every little bit of volume they have left. It's not saving their lives. And we don't do this enough Again, I mean, I'm sure if you work in a large urban area, you're running a lot of trauma. Or if you work in a trauma facility, you're working a lot of trauma. But for those folks working in like suburban departments and things like that, we run way more medical than we do trauma.
Right.
And it's two totally different pathophysiologies. And we have to understand that.
Vast majority of people in cardiac arrest that are older with comorbidities, it's a pump problem.
That's right.
That's typically what it is.
Yep.
It's typically what it is. A younger person in the context of trauma, it's a hose problem.
That's right.
It's a hose problem. The pump is fine.
That's right.
Typically. There are some exceptions, and we have to be careful.
Yeah, nothing's definitive. Nothing's 100%.
Here's a great story that kind of illustrates this, I think, really. A 19-year-old kid was walking across the street, hit by a car, massive injuries, and he had head injuries, and there's some extremity injuries. One extremity required a tourniquet, just bones in a bag. I mean, the leg was just munched up.
Yeah.
And the patient came in. They were doing chest compressions because they couldn't find pulses. And, pulseless patient equals chest compressions is the mantra typically.
Yeah.
But in the context of trauma, now the evidence isn't. I mean, we follow your protocols, but I think we're causing harm in certain situations by doing chest compressions where these people don't have a pump problem. Why is pressing on the chest doing any good when the problem is down line?
But they don't have a heart rate. They don't have a heartbeat.
And why not?
Doctor?
Why not? Why don't you feel pulses? Why didn't that 19-year-old have pulses?
Well, more than likely is because his volume was so low that the pump was working fine, but it's like, again, think of your fire truck. If you have no volume coming out of your pump, what are you going to have at the end of your hose line? You're going to have zero pressure.
Looking for pulses. I don't feel pulses. Start the...
That's right.
Right?
That's right.
There was actually a pulse there. You just couldn't feel it because the cardiac output was so low. Not all the time, but typically
pseudo-PEA
in a young person with a traumatic mechanism, be very careful with these things. And
look for other signs. If you have ability to do ultrasound the heart. See if there's motion. You can do other things to see if they're actually flowing blood. You can look at other things.
So let me finish my story now.
Oh, sorry.
No, it's okay. No, this is really good to talk about it. So this 19-year-old with all these injuries or whatever, chest compressions, right, couldn't get a pulse back. I mean, couldn't get a pulse back.
Right.
Pulse never left, actually, in my opinion. But as soon as we got blood, and just think blood pressure's there,
was he in
pulses
PEA?
are strong. Pardon?
Was he in PEA on the monitor?
Yes.
Okay, so they saw the rhythm. Okay.
It was rhythm. If you're in asystole in a traumatic situation, that's a totally different ball of wax, right?
Just double checking.
But this patient, so we see electrical activity, as we're doing chest compressions. They're brought in doing chest compressions. And as soon as I got that massive transfuser putting blood in this guy, immediately the blood pressure is back. He's got pulses. Yeah. Unfortunately, he didn't survive, but it was clear to me what was going on. He had massive hose problems. Yeah. Unable to perfuse his organs.
That's right. And another thing, we talked about permissive hypotension. You look at the MAP, which, most EMTs or paramedics, they don't really learn a lot about the MAP, the mean arterial pressure. And basically all that means is what is the point of the blood? It's to keep the organs alive, right? Perfused, right? Keep the brain perfused. Really, we were just talking about this the other day. We're not doing chest compressions in a cardiac arrest situation to keep the heart alive. We're keeping the brain alive.
We are.
That's what we're trying to do, right?
Brain cells, very hungry for blood.
That's right.
Need the sugar, need the oxygen.
Exactly.
You starve a brain cell, it's gonna die and swell.
We've all seen it where we give enough epi or we shock enough times that we get a pulse back. But the brain, noxic brain injury, right? They were taken off the vent, right? Yeah. So our goal is these patients to survive and walk out of the hospital, right? Yeah. So we talked about permissive hypotension. If you look at that MAP, which most of your monitors, it should be a small number right next to your blood pressure. And there's some
2/3 diastolic, 1/3 systolic.
That's
it tends to be a little closer to the diastolic number.
Correct. And in hospitals 60, 65, typically. But some
say 70.
Exactly. 70. I've heard trauma people say 35 to 40 in a life-threatening situation is enough to keep things alive. To get them to you hear people say all different kind of things, but again, your blood pressure doesn't have to be 120/80. Right. Just remember that as a provider that if their blood pressure's 90 over whatever, That's okay. Keep it at that. Like you said, look at other things. What's their skin color? What's their mental status?
Mental status.
Yes.
When I get a call, an online medical control call in a situation like this, I'm going to ask, what's the patient's mental status?
What's their GCS?
They're talking to me. Well,
keep them talking to you.
Yeah,
Get them to me.
Don't
That's
worry
right.
about the blood pressure. 90 over 50, perfect. Keep talking to them.
That's right.
If that changes, we may have to do something different. But for now, let's hightail it to a place that we can fix the problem.
Yep. Keep them on oxygen. Watch for hypoxia. Watch for hypothermia. Keep them warm, right? If you can start IVs, give them a little bit of fluid. I wouldn't give them more than 250, 500 probably.
The data says 250 cc's of NS in these traumatic situations may not cause harm.
May not cause harm. Yeah,
so
exactly.
it doesn't say it helps.
Right. But it
just
might not hurt them. Right.
So
if you can give blood, give blood.
Yeah. In some situations, it's different. But in a traumatic, acute blood loss situation, you'd be very careful about what you do with fluids.
That's right.
It's not something to be taken lightly. It's not something we should just be reflexively doing.
Right.
And then trauma, okay, bilateral large bore IV, slam a liter of fluid.
That's what we
go
did
to the trauma center.
back in the day.
That's kind of the way, and it's still today in a lot of places.
Yep.
So we have to be careful. We got to change that paradigm.
Yeah. I think the big takeaway is, these events, and it's a sad thing to say, is that these, whether you want to call them terrorist attacks, whatever the case may be, these mass casualty incidents are becoming more frequent. And if you haven't had one in your town, I hope that you never do. Yeah. But the likelihood of you having some sort of a mass casualty incident is increasing.
It is.
They are not just happening in urban areas. They're happening all over the country. Yeah. And so the big thing is that you need to be prepared. Yeah. You've got to do your homework. You've got to understand your mass casualty triage system. You've got to have equipment ready to go.
Know how to use it.
Know how to use it. Know where it is. Know how to use it. Practice with it. We do that numerous times in my department. We just recently came out with a separate bag, trauma bags, that carry a ton of tourniquets, all these kind of things. Everybody should be doing that. It's a sad state of affairs, but we can't ignore the fact that this is what's happening. Yep. So I heard, great job to the New Orleans EMS folks. They did the best they could under really bad circumstances.
And I'm sure that the law enforcement folks are like this too, but I know out here they're carrying tourniquets. I think everybody's carrying tourniquets now.
I think that's pretty standard.
It's pretty standard.
Yeah.
Which is not always
typically
not
only
always
carrying
been the
one.
case, though.
No,
it's not always been the case.
Definitely not. They're typically only carrying one in their belt, though. But and they're getting more comfortable with using them.
A lot has changed, and we talk about this in our lecture with our military experience.
Yes.
And then experience with the Boston bombing.
Yep.
I mean, I think I'd read only one conventional tourniquet was used.
Yeah.
So we've learned a lot.
Yep.
And there's more to learn. There's more to learn.
I'm sure we'll learn more from this last incident, too.
Yeah, I'm sure we will.
So, it's an interesting topic. And watch for a hemorrhage lecture. It's a good one.
Yeah, and I think, again, it's worth saying just our thoughts and prayers are with all the people involved and families affected by this.
Absolutely. And the first responders that had to see that stuff.
Trauma of it.
Absolutely. Yeah, police, EMS, everybody. Yep. Terrible situation. See you in the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.